it is something that sometimes will go down the surgery route, unfortunately. But yeah, we'll go through, when we do our practical bit, which we will do in a second, just to get a little bit moving, we'll go through a bit of those as well. All right, so I'm just going to whiz through abdominal pain next, and then we'll have a break and do some movement stuff so we can get up and moving. So pelvic and abdominal pain. Like I say, oh, hold on. We're thinking a little bit more about that sort of anterior area again still, but we're thinking a little bit more, and we're going to talk a little bit more about sort of the persistent pelvic pain that we see. So it can be a bit of a diagnostic challenge. Is it one problem? Is there a few problems going on? There's a lot of structures that we've spoken about, but like I said, we just need to be a little bit more aware of what can intersect. Some of the things that we see in a pelvic health practice is Dysmarinaria, which is painful periods, and that endometriosis, bladder pain syndrome, which is really common, or interstitial cystitis is what it used to be called, where they're feeling like they're kind of constantly getting those UTI side of things, or if they're having bladder urgency where they're kind of constantly going to the toilet. Prostate pain is super common. It doesn't necessarily be cancer, but they can just be prostate enlargement, and lower back pain, all refer into this area. Pelvic girdle pain with pregnancy we'll talk about a little bit more in later. Pelvic floor muscles, obviously something that we see as pelvic practitioners, and probably not if you're not doing that region, but just be aware that those muscles can refer into that area as well, the anterior hip, the internal thighs, and into the tummy. And it's really common to have pelvic floor pain if you've not had a baby. You could be a man, you could be a woman. It doesn't have to be just your post-pregnancy kind of side of things. It's really common to see really stiff muscles in that area. And again, it's really important to ask about those issues with their kind of bladder and bowel from that side of things, because it might just point your direction down that way. If we have really stiff pelvic floor muscles, things that I would always be keeping an eye out for is maybe painful sex, and that's for boys and for girls. Like you might have with women, obviously pain with that penetration side of things, but with men, they can have pain after orgasm, pain with erection, and that can be indicative of pelvic floor muscle tension. And that's not always because of an injury or an infection. It can just happen for most of us just from stress, or as girls, I don't know about boys, we hold our tummies in sometimes a lot too much, and that in itself can also cause pelvic floor muscle spasm. The other things that would change if there's a lot of pelvic floor tension is that you would usually have some issues or some changes with your bladder and bowel. So someone might say that they sometimes go to the toilet and it takes ages for the wee to come out, and that can be just because the pelvic floor is actually not very good at relaxing. So if they're saying that, or if they're having a history of constipation and they're not relaxing in that region as well, this can all be indicative maybe that we're just thinking pelvic floor muscles, which, like I said, can refer really strongly into the hip, into the tummy, into the inner legs. So if you've treated this patient for a little while and they're just not getting better, maybe think about asking those other few questions about the bladder and bowel changes, or if they have any pain with sex. And it might just be one to think about and maybe refer on to somebody who's happy to do an internal exam. Coccydynia, it's something we really commonly see. I think probably all of us in all of the fields, obviously pain on that coccyx region. Again, it can be really common after falling on your bum and having an injury, and it could be something that happens when they're really young and they don't think about for ages, and then they maybe re-injure, or maybe they get pregnant, or they've just gone for a horse ride on holiday and it's just flared it back up. So coccyx dysfunction, again, is a really important one to think about, because it's a really common one that becomes persistent. Because it's an area that we're not very good at ignoring. If we're sitting on it, we're constantly feeling it. It's an area that can constantly be aware of, and then it becomes more and more stressful, and it can kind of send it into that central drivers. So it's a good one to get better at. A lot of us, I would start always in terms of coccydynia and looking at how they're sitting, but also having a bit of a feel of all those muscles that are connecting in, piriformis, all those kind of internal glute muscles. But then again, if it's not improving, it might be again one that you refer on to somebody who's happy to do an internal check, because it is pelvic floor muscle insertions onto that coccyx as well. And if they're super stiff, they can also influence the direction of the coccyx and not allow it to move the way that we'd want to. So if you're not having any success with people who've got coccyx pain, again, it might be something that you think about referring on to someone who's a pelvic practitioner. IBS, I think we've all heard of IBS. A lot of people probably say that they have IBS and they don't, but the clinical decision for IBS is you have to have pain with your bowel movements at least once a week. So even if you're swinging from diarrhea to constipation and back again, it doesn't necessarily mean you have IBS unless you're having that pain associated with it. But it is something that we do see quite clinically commonly. And again, it can refer quite a lot into lower back pain, into abdominal pain, and we really often see it coming along with your endo or with your bladder pain syndrome as well as a comorbidity, as well as that lower back pain. And again, it's something that they can't necessarily grow out of or get over. So it is something that's that persistent pain that we should tend to see and just tend to be aware of. Pudendal neuralgia. So pudendal neuralgia is the pudendal nerve, which supplies basically the genitals and part of the bladder and bowel. And they're usually going to present with that kind of saddle pain rather than saddle numbness. So it's not that quarter equina side of things, but we do see this with cyclists, men and women, which can cause some trauma as the pudendal nerve exits through that obturator canal. So again, it's one to be really aware of if they're having a lot of burning or really severe pain in that kind of genital saddle region. Again, they can improve quite well on it, but it is one that can quite quickly become a persistent pain and quite stressful for people if they have it. So that would be one that I would refer on. Again, we've talked about this a little bit previously with our biopsychosocial model, but this is kind of the psychological factors that we just have to be a little bit aware of. So precipitating, you know, have they got that kind of acute emotional trauma when they're having this pain condition? Have they had a recent loss? Are they stressed? Have they got recurrent abuse? It's always going to predispose them a lot more to pain. And if they're having that persistence of stress disorders or stress factors, do they really hate their job? It can really have that kind of nocebo effect of kind of increasing that painful stimuli. And yeah, if they have a predisposition of anxiety or depression or abuse or relationships or PTSD, it has been shown that they're more likely to have pain or persistent pain disorders, as well as a lot of other things like heart disease or lung disease or whole host of problems. But just some factors, again, just to be aware of that can continue to drive these conditions. Just some quick stats. But women with persistent pain, pelvic pain, report higher levels of depression, anxiety, sleep disturbances, sexual dysfunction. So it's a bit of a chicken and egg, but yeah, it can definitely go both ways. Up to 60% of persistent pain don't have a specific diagnosis, which can create great anxiety. So it's a really tricky one. I think sometimes giving someone a diagnosis, sometimes they can really latch on to that and it can maybe not be the best thing, but I think there's a lot of anxiety of not knowing what's going on. So if you aren't going to give them a specific diagnosis, you still want to really reassure them that there is things that they can do and ways to kind of improve in this area, because I think it's really anxiety inducing when they just have no idea what's kind of driving that pain. And if it is central drivers, you want to be really careful with how you explain that as well. So if you can't just be like, oh, it's because you've got a really stressful job, like you're just getting all this pain, you know, you've really got to take that really gently and explain things in a certain way so they don't think you think that they're making it up as well. Compared with controls, men with that CPPS is chronic pelvic pain syndrome have higher anxiety and depression scores. So that's a really high number. We're seeing more and more CPPS with younger guys. Again, it's something we see a lot with if they've got a history of IBS, bladder pain syndromes, that depression, anxiety are really high. And again, it's a bit of a chicken and egg, because if they're having issues in pain in the pelvis, problems with erection, problems with, you know, bladder and bowel, obviously that's going to be quite anxiety inducing and just drive that pain around in circles. So it's a really important one to be aware of and something that we can treat really successfully once we get hold of them. I actually didn't put this up there, but the average time that it takes for people to come in with chronic pelvic pain to see a physiotherapist, for men it's 10 years. So they've had these symptoms for about a decade, and it's taking that long to either reach out, but often they're just getting referred around, and they've had every test in the book before they come and see a manual therapist for something that probably could have been really successfully treated if we'd kind of caught them in that initial acute phase rather than waited till they've got to that point where we've got all these central drivers and it's become a persistent pain condition, which makes it a lot harder to get on top of. And yeah, depression, helplessness and catastrophizing predict levels of pain. So a lot of us as physios will get them to do some kind of pain questionnaire in reception, you know, when they're doing their initial goals or like what they've come in for back and pelvis wise. So a lot of clinics have implemented that, where you quickly get them to do a screening that might give you just a really quick snapshot.